Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor and author at philplisky.com and a performance systems consultant in professional sports. Being a physical therapist and athletic trainer and strength and conditioning coach, we like to come at this from multiple perspectives. We want to give you the latest research-based information, but most importantly, we want it to be practical and useful for you tomorrow. I'm looking forward to our topic today, which is pain neuroscience education. Does everyone need it, and what does the research say? I'm joined by Adriaan Louw, who's an expert in pain neuroscience education. Welcome to the podcast, Adriaan.
Hey, Phil, nice to meet you, and thank you for having me. Happy to be here.
I'm so looking forward to this. This is going to be great. Can you get us started by telling us a little bit about your background?
Yeah, I'm a physical therapist, or in South Africa, where I'm from, we call them physiotherapists, but I'm a clinician, a researcher, an educator, an author, a little bit of everything that I do, but all related to pain science now.
That's awesome. So tell me, what got you interested in this? What got you attracted to this topic? Because admittedly, it might be something that a lot of people would avoid because it's pretty complicated and pretty challenging.
Yeah, Phil, I think most young clinicians want to end up where you are, right? Sports medicine, that's what all young clinicians tell us. No, I never went this way planning to do it. The easy answer today is I failed. I was trained as an orthopedic manual therapist. I had tools at my disposal, tried to help patients. And, I think when you have a funny accent and you have that idea what you're doing, you start seeing more complicated patients. And I just found myself at a point where I couldn't help people anymore, especially more complex patients. And then as luck would have it, as divine intervention would have it, I was pulled into the world of pain science very early on. And it just made so much sense to me. And then one step leads to another. And then here we are, years later, having an interview with Phil on pain science.
Oh, that's fantastic. Yeah, it's pretty amazing. And it's pretty neat to see the evolution of it over time. It's really gone from, not a thing in the beginning of my career to, a pretty substantial, pretty important thing. Why do you think it's important for us to discuss this? What questions should clinicians be asking? What is the clinical application of this?
Yeah, Phil, obviously I'm biased, right? I'm going to tell everybody they need to know this stuff, but the reality is about 1 in 5 people in this world suffer with persistent pain. In the old days of therapy, you could kind of hide from them. I'll be honest, I worked in a big sports performance clinic where there was a group that specialized in knees and backs and shoulders, and then there was this chronic pain guy in the back that, was treating people with chronic pain, but you cannot hide from it. And you are a great example, but I speak now to NFL teams, to NBA teams. Kids have pain, adults have pain, older adults have pain. Pain is everywhere. Mm-hmm. And if we really want to impact pain in general, and again, nobody really moves in that direction because they want to go that way. Now, let me just preface, there are a few, and I think the world of them, that this is their calling, but most of us normal therapists just want to treat a good old shoulder and a knee and a back. But we're going to
do some manual therapy and exercise and call it a day.
But we should all have a working knowledge of how to do it. And that's, I think, what excites me is that my goal is not that we suddenly have 200,000 therapists at all pain science. No, we have backs and necks and knees and shoulders that need help that don't need pain science. And I think that's kind of where we're going today. But we have to understand, because 1 in 5 people do suffer with some form of persistent complex pain.
So it's a pervasive problem we all experience with patients on a daily basis, that we know it's a problem. Heck, you can just go to a family gathering and know that it is a problem. But what does the research tell us about this? Like, what are the highlights? What are the key takeaways that, boy, you really need to know this about P&E?
Yeah, I think the big thing is about pain neuroscience education. The way I look at it is we talk to patients anyway, Phil. Right? A patient walks in, you tell them about their shoulder and their knee and their back and et cetera. Or better yet, we talk about, hey, how's the Packers going to do this here? And how about that rainstorm we had last night? We communicate with people every day. And what the research just shows us, if we take some of our educational time that we talk to patients, but actually inform them more, teach them more about how pain works, their lives are actually better for it. In our domain, we talk about things like fear avoidance and catastrophization and words that harm, words that heal. But we have now actually taken this concept that all clinicians do, i.e. talking to people, and shown that a specific form of it actually is therapeutic. We can show you in brain scans how those brains calm down. We can show you people move better. And so my message to therapists is, why wouldn't you do this? And hear me correct. I do want to talk about the Packers. I do want to talk about the rainstorm and the farmers need some rain, but maybe I can just add a little bit of information and people go, oh, wow, that makes sense. And thanks. I feel better about it. And now it's an oversimplification, but it really is something we do anyway. And why not take advantage of it?
So it's something, one of the interesting things I hear you talking about is almost more sprinkled in than a major, like, I think there's a big push out there, and I don't know that it's what maybe the researchers in this area have intended, is like, oh, well, you just need to talk to a person about their pain and, have hopefully everything else goes well. How do you see this playing out in translating into the clinic? What does it look like in a patient encounter for you?
Well, let me tell you, I'm going to go the other way first. The way it was designed, pain neuroscience education was designed as a technique. Right? Phil walks in, he meets certain criteria, and based on everything we know, which we can discuss more today, everything tells me that Phil needs to learn more about his pain because he's afraid of his pain. He's not moving well. He's got some catastrophic thought processes about it. That's it. My season's over. That I would then sit with you and say, hey, Phil, let me teach you a bit more about how pain works. Why is your pain spreading? Why, when it's cold, you feel your shoulder more? We make the unknowns known. And that is what most therapists know. When we go to CSM or the big conferences, that's what we teach. You walk in, patient meets criteria, we do this technique. So P&E is a very definite, in one way to look at it, as a technique. If you meet certain criteria, no different than a clinical prediction rule or a practice guideline, then we do this technique. And the outcomes are really amazing if you look at the evidence and the research. But what you're talking about is actually something we found about 3 or 4 years ago, and we call it not pain neuroscience education, but pain neuroscience communication. And it is this idea of almost sprinkling the words. And you know what happened, Phil, as you know, I mean, we teach a lot. You're an educator. We travel all over the world, whatever. And then people come to me and say, you know what, Adriaan, I can do it in the clinic, but what I'm finding is my day-to-day words are changing. I'm softer spoken. I'm less expressive. I use softer words. And Yo Nice, who's one of the world-leading authorities, we do a lot of work with him, talks about this idea of pain neuroscience communication. It's almost like that thing we sprinkle throughout. Now, as a scientist, it's almost impossible to measure that. It is control for it, but I found it very intriguing. I'm like, that's kind of cool. Right? Maybe people are not ready to jump to the pain side and let me tell you about your pain, but let me at least reduce my words that harm and words, and softer spoken, less expressive, those kinds of things, which has therapeutic value.
So, so what that really, I see that, there's very similar lines here in intersections. We had a previous podcast talking about contextual factors and how those impact pain. We've talked about therapeutic alliance and how those can impact pain. And what you're really saying is what I hear from you saying is these are all intersecting. And like we think of manual therapy techniques, we think of them as a discrete event, right? Like, I'm going to assess, I'm going to determine that this is the manual therapy technique that needs to be done. And then I'm going to do this one technique. You're saying that this communication style is a communication style, not an event.
It can be either or, right?
Okay. So we could do both.
Absolutely. And that is really how we teach people, especially with the more complex patients that have been everywhere. They don't know what to do anymore. Let's sit down and talk about this. Then it's very overt, but we find it very intriguing, this idea of almost sprinkling it, right? And then if you think about it, if 1 in 5 people have chronic pain, let's use the numbers, Phil. Let's say a therapist sees 10 patients a day. That means 2 of them are more complicated, right? And that's the patient you sit down and say, hey, Phil, today we're going to talk a little bit more about how your pain works. But the other 8 are coming in for their back and the neck, the knee, the shoulder, the ankle, the foot, is sprinkling it during that. Okay. And it's kind of a little bit of both. And that's what's exciting.
So it depends on the patient. So let's see if we can identify that a little bit. Are there certain patients or conditions that this is appropriate for, where you're like, I'm going to do this as an event?
Yeah, absolutely. We've studied it. I mean, I would tell you the last 5 years, there's been a lot of research in this field. And it's simple. There is a list. It's a very significant list. And we now know that when patients show up the following ways, they are ideally primed to do it as a technique. Let me sit down and talk to you.
Yes.
People with central sensitization, and this is typically where pain is all over the body, nothing helps, it's been everywhere. I'm oversimplifying, but central sensitization, which has been renamed nociplastic pain, is typically those patients that have been everywhere. They literally have no idea where to go anymore. People with chronic pain, and chronic pain, I mean in duration. You've had pain for 6 months, 9 months, or longer, because you've seen multiple doctors, multiple opinions, multiple scans.
I think that's an important distinction to make for our listeners there, the difference between the nocioplastic pain and chronic pain. Those are two different things, because one is time-based and one is where the pain is located and how long it's been going on and that type of thing. Is that fair? Absolutely.
You can have chronic nociceptive pain. And that is just where you have a bad ankle that is just it's localized, but it's been there for 3, 4, 5 years. They're two very separate events. You can have chronic nociceptive pain where you can have, actually you can develop nociplastic or central sensitization within a couple of days of a motor vehicle accident. So time is two different things when it comes to pain. But yeah, they're two different things.
That's important. I think that's a huge distinction there.
Yeah. The third one, which I think most of our listeners would probably know, is really high levels of fear. Fear predicts pain so powerfully. We know it, fear avoidance for injuries, those kind of things. They do well with this because they're so afraid. And typically they're afraid to move anyway. So we've got to do something to get the fear down. That works. Hand in hand with this, Phil, goes pain catastrophization. And that is kind of the cup is half empty. That's it. It's my senior year. I hurt my ankle. I won't play this year. So they're always catastrophizing. And pain does that to us. And the last one, which I think the listeners really need to know about, because this is a tricky one, and that is people that are not pre-contemplative. And if you think about it, in behavior change, right? So Adriaan needs to lose weight or he needs to stop smoking. Pre-contemplators are people that don't want to change. I'm fat and happy. Let me be. I'm smoking. I've decided. Let me go.
The risk doesn't matter to me. So I've already decided this is where I'm at.
Correct. And a pre-contemplator in therapy sounds like this. I'm only here because a doctor needs to give me my medicine. I'm only here to get my wife off my back. Sorry, kind of a bad pun.
Right, yeah.
That's kind of what they say. I'm only here because work comes sent me here. Those are not bad people, by the way. We're just catching them at a different part in their journey. But what the research shows is if you sit down and do a cognitive intervention, trying to change how they think, it doesn't go well. And every therapist listening right now that have had a bad experience with pain neuroscience education probably missed that step. I did it for many years. So people that are contemplative, like, what do you guys do here in therapy? What can you do for me? They do well with these kind of approaches. So there's really those 5. People with central sensitization, chronic pain, high fear, high catastrophization, and people that are ready to change their behavior. They do really well with it as a technique.
That's awesome. So, one of the things I'm really big on, for whether it's manual therapy or exercise, that we're going to be systematic in our approach to prescribing it, right? We don't just say, okay, well, you have knee pain, so we're going to do straight leg raises. That's ridiculous, right? I think we're all beyond that. But seriously, we want to be exceptionally systematic. How does this play out in the clinic? How do I assess to determine whether this is through questionnaires, whether this is through my historical examination of the patient? How does this play out in that patient thing to determine, hey, this person is ready for all intensive education session, and maybe that's the way education session, communication session versus this is going to be sprinkled out throughout my language throughout the course of time.
Yeah, that's a great question, Phil. The cool thing today is that everything I mentioned, it can be measured. So if we start with central sensitization, we know there's actually a bunch of criteria or a cluster of signs and symptoms, but there's a questionnaire that's becoming very common in clinical practice called the Central Sensitization Inventory. So if you walk in my clinic and it sounds like, tastes like, smells like Phil's hurting everywhere. I may send you home with it. I say, fill it in. There's a cutoff score. And so if you score about 40 on that questionnaire, then it tells us you're probably more centrally sensitized, as an example.
Right.
But there's also criteria, right? Widespread pain, diffuse palpation, tenderness. It's well documented. That's easy. Chronic pain's easy. It's time dependent. In America, it's 6 months or more. So that makes sense. Fear avoidance. I think it's almost, Phil, you can correct me. You're in this field too. I think it's almost, do I even say the word? I almost want to say it's criminal if you're an orthopedic therapist and not using a fear avoidance questionnaire nowadays, right?
Yes.
And I think most clinics are using a FABQ, which was designed for back pain, but now do it for anything. A Tampa scale of kinesiophobia can be used, and they've shown us there are cutoff points. If you're really high on those, so we can screen. Catastrophization, there's a scale you can use. So we can pick these things up pretty easy. Or if you don't have those, you don't use those, just listening. Right? When patients are saying, I'm afraid to bend my knee, or, I'm afraid my pain's going to get worse, they're telling you, I'm afraid. So you may not give them the questionnaire, but wait a minute, let's delve deeper. Right. The only odd one is going to be the last one, right? There is actually a behavior change scale you can use, but I truly believe in that initial interview. I'm going to get a sense of, do you want to be or do you want to do therapy? Are you ready for it?
Right. Am I sitting there with my arms crossed being like, I can't get my MRI until I do my 2 weeks of therapy because the insurance company won't pay for it, is a different person than someone who's like, all I want is to be out of this pain. I want to be able to pick up my kids and move on with my life is a different person.
Absolutely. And so you should be able to pick those up. And then if I pick these signs and symptoms up early on, I may just turn to the patient and say, hey, Phil, since you've had back pain, for 3 years, what's the biggest thing that's been bothering you? And you say, Adriaan, when I get stressed, I feel my back. And I will just ask it, hey, Phil, has anybody ever explained that to you? And it still shocks me, right? 99% of people are like, no. And then I would just ask permission. Would you mind, before we do some stretches, your last therapist showed you these stretches. I want to see what they've shown you. Would you mind if I teach you about why when you get stressed, you feel your back? Now, you still have an option. Can you go through
that? Just give me a little example of like, hey, it's cold out. It always hurts more when I'm cold or when I get stressed, my back hurts. Talk to Phil saying, I just told you that.
Okay, so you're telling me, Adriaan, I'd like to know more. So we use analogies or examples or metaphors. So I say, no, Phil, and I show you maybe a body's nervous system. I say, Phil, our body has a living, breathing alarm system called the nervous system. There are over 45 miles of nerve in the human body. They're all connected like a road system. So if you move your head up and down, the nerves in your back move. They all work, but inside of these nerves, which work like an alarm system, that's our metaphor. They're buzzing along, enjoying a beautiful day, at home, right? Now, what happens if you bend over and you lift something, you hurt your back, the alarm goes off and go get some help. The alarm goes off, ding, 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 go get some help. So what do? We go to the emergency room, doctor sees us, make sure everything's good, and we go home and life is good. Well, this alarm system you have, which, by the way, the best of the best on the planet. This is, I should be careful of names, but this is the best. I want to be careful of commercial names, but this is the best of the best alarm system on the planet. Do you know that our alarm system don't only tell us when we step in a nail, ding, 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 there's a nail in your foot, or you hurt your back, ding, 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 go to the emergency room. But this alarm system also has sensors in it. This alarm system can actually tell us how hot or cold it is today in wherever you live, right? It can tell us if you're stressed or not. And so all I want you to know is there are sensors. And when our environment changes, the alarm will say, hey, Phil, it's cold outside, put on a sweater. Or, hey, you're stressed, calm down. You're going to run into some trouble, right? So we use these analogies where people go, oh, okay, so what does it mean? If you get stressed and you feel your back, it doesn't mean there's something wrong with your back. It just says, hey, you're stressed. Let's work on stress. So what do we do for stress? Well, breathing, relaxation, mindfulness, by stress reduction. So a quick and dirty version, but it's we take this because people think if I feel my back when I'm stressed, there's something wrong with my back. Well, I have examined you and everything looks okay. You're healing well, you're moving okay. And that's kind of where we start putting these metaphors together.
That's fantastic. One of the things I heard you say, even when we were talking about the criteria of who this is going to be successful for and who it may not be successful for, you said something about, I'm going to give you this questionnaire and have you take it home. and come back. I think there's a big misconception out there, and I see this a lot when people have taken a great education course, and this happens regardless of whether it's manual therapy or exercise. Yeah. But the person says, "Hi, I have low back pain, and now I've got a book out, and I'm telling you exactly everything that I learned over a weekend, and I give you a 20-minute spiel from a book." And the patient, I've heard reports of like walking up and leaving and things like that. Well, I'm hearing that you take this a little bit more slowly than we're just, "Hi, how you doing? Let me tell you about your pain."
Yeah, well, this is going to sound so terrible. The good thing about chronic pain is we're going to see them for a while. Mm-hmm. So there's no rush. Right. And so the way we look at it, Phil, is I'm going to build a relationship with you. So we sprinkle questionnaires over time. Visit number 1, there's the standard stuff every clinic has to fill in. And that's already a lot of paperwork. So I'm not going to give you 30 more forms. But right. As I get to know you at visit 1 and say, "Hey, Phil, it was so great to meet you today. I cannot wait to see you, by the way. You're going to come twice a week. A session will be about 40, 45 minutes. We're going to cry together. We're going to laugh together. We're going to have some rough days. We're going to have some good days. But I'm going to get to know you. And would you mind to take this one form home for me tonight? Just, get something cold and crisp to drink, a nice Chardonnay from South Africa would suffice. And then just fill this out." And so as you go through your sessions, I may build a profile. You sound more fear avoidant, so I give you a fear questionnaire. Or maybe I can pick up a little depression, so I give you depression. So we tend to build a profile over time as we get to know it. But you're right. If we just give you all the paperwork up front, that's what we typically would do. And it works pretty well because, I'm going to go back to kind of the essence of P&E. Theodore Roosevelt, one of his famous quotes, Phil, is, "People don't care how much you know until they know how much you care." And so, when our pain fellows graduate, they get their plaque, rah, rah, rah. But we give them that plaque too, because I have so many people, and you would be the same. People email me, "Dear Adriaan, I took your course and I tried it and it failed." And then I just write them back and say, "Okay, tell me the following things about your patient. What sports are they into? Tell me about their kids." And they write me back, "Well, I don't know those." And I say, "You don't know your patient, so don't email me." You got to get to know the human being. What are you here for? How can I help you today? In this 40 minutes I'm seeing you today, how can I make your life better? And it's that kind of scenario. It's not just shove, shove, shove. We did it, Phil, by the way. 2003-ish, when pain neuroscience became a big deal, you'd walk in the clinic, we'd give you these fire hydrants. "Let me tell you everything I know about pain." Just boom, boom, boom. And that's where you hear these things where people just stormed out. And we did it. We made the mistakes. We learned from the mistakes. And I feel way better now. It's like you're planting little seeds and you water with compassion and empathy and just watch them grow. That's really
so right there. That's it right there. So you're planting seeds, watering with compassion and empathy, because one of the leadership principles that I love is when you're having to coach someone who maybe is an employee that's not doing what they need to be doing or whatever, but before you kick someone in the rear, you need to have your arm around them first, right? And what that is saying is a very similar concept of you is you've got to have that relationship. You have to have that trust. Yeah. Maybe even before you broach the subject or sit down with a formal education type of thing. And I'm loving this concept of, pain neuroscience communication, or maybe it's really probably even a bigger picture of relationship building, which is hopefully most of us who are in rehabilitation are in it because we spend time with our patients. We see them for a long time. We see them for a long period of time. And so we're usually pretty good at that. But if we can become better relationship builders along with better educators, and maybe the word would be better coach, right? So we're not forcing someone, when you say I'm going to sit down and do pain neuroscience education, well, you know what? I'm just like with my kids, I'm just taking medicine and just trying to shove it down their throat versus like, hey, trust me first, get to know me first. And I'm not going to make you take the bad tasting medicine all at once in this first session.
Absolutely. Could not agree 100%. It makes sense. You get to know the person first, and then you slowly walk this path with the patient. The really tricky part, Phil, is and the clinicians would understand this part, but what really, I don't want to say frustrates me, but you plant the seeds with the patient. you water it, and then some of them blossom right in front of you. You think, man, I'm the best therapist in 9 counties. Yes. Then another patient, you plant the seeds, and it visits 78, they go, I got it, right?
Right.
What it gets me is a patient where you plant the seeds and they say, yeah, I don't think therapy is working. And they leave your clinic, and then they go to your competitor across the street, and that therapist plants the last seed.
Right.
And the cool thing is
you've tilled up the ground, you've planted all the seeds, you've watered it, and then something germinates, and it's just like, man, it would have germinated if you weren't there, right?
But the cool part is it germinated. Yeah. I'll tell you a funny story. I mean, I think most people probably associate me with a little bit of the pain science stuff, but I was at the grocery store a while back, and this patient, an ex-patient, walked in, and I said, hey, how you doing? He said, oh, Adriaan, it's great to see you. And I said, how you doing? But it was one that I failed with. It didn't get any better. And I kind of like, how you doing? And he said, I'm doing great. I'm doing great. I said, oh, fantastic. What happened? Oh, I went to this therapist. Yeah. And what did he do? Well, you got to look this thing up. It's called pain neuroscience education.
You know what? As a matter of fact, I think I saw a YouTube video somewhere on that. I may just have to go look into that.
It was so much fun. I mean, it's like, and obviously I played the role. I said, that's great. I'll look into it, and fantastic. But that's the cool part about the human interaction. We're catching people at different parts of their journey, and we're just there to walk maybe the beginning steps, the middle steps, or the end steps, and wherever they are. And that ties to what you're talking. I mean, you use trust, you use therapeutic alliance. A lot of that ties into it. But I need people to also understand these aren't soft skills. They are very adamant. If I put your brain in a brain scanner today and I do these techniques with you, there are significant. So, Bill Boysenall, who everybody knows and is brilliant, and I think the world of Bill Boysenall, a few years ago, he got an award from Aon, and he made his keynote address, and he said, these aren't soft skills, they're essential skills.
Yeah.
And I mean, I got like hair standing up on my arm when he said it, and I said, yes. It isn't soft skills. And I don't want people to listen to it and go, oh, you just have to be nice and friendly. You're going to be good at what you do, because it is a little bit of a play of going left and a bit of right as you work that person through the process. So absolutely, it's a skill.
Well, and that's an important thing. I mean, and we're seeing, and that's what I think it's interesting to me about therapeutic alliance, contextual factors, P&E is, we in some respects want to dump them all in the same bucket and go, it's the same thing. But what you're saying is there is science that if we use particular verbiage and particular ways of not talking to the patient, I think is probably, in education, we always have the standard line of it is, if I went and tried to teach everything I know to everyone, that's not hard. What's hard is what not to teach, right? And in this case, a similar analogy is what not to say, what not to do. And there are particular things that you say that can be harmful. Yep. There are particular things that you can say that can be helpful, and you wrap that in a coat of a high quality relationship and a high quality communicator and caring and compassion. You've got some brilliance there.
I think that's one part of that, Phil, that people often miss. And it says, you got to be good at what you do, at your skill. I always tell therapists, be good at what you do or leave my profession. I'm not trying to be rude or angry to you, but patients know when you're fundamentally good at what you do. A little while back, somebody asked me on a podcast, same thing they asked me, how come you're so good at chronic pain stuff? I said, and I don't know why, I just blurted out. I said, because I'm a good manual therapist. And I said, what does that mean? I said, because I do thorough evaluations. Yeah. I do thorough clinical reasoning. And then I go to where I need to go. And so I think everything you just said there brilliantly, right? It's all these little pieces, but you also have to be good at what you do. And the patient needs to go, I got it. This guy is good. I can feel it. I can sense it. And he or she cares what they're doing and helping me today.
So again, empathy, compassion. But with that said, effectiveness, you have to have buy-in from another modality, if you will. And I hate to use the word modality, but let's say another intervention. You have to have effectiveness with another intervention such that they believe you, because you're going to be talking about something that, you're not going to talk to them and their pain's going to be gone in a minute. Like, that's not going to happen. So they have to believe you. So you probably need a lot of other tools that are effective immediately so that they do believe you. Is that fair?
Absolutely. Phil, I've been trained by the best in the world. I've been doing this for decades, published a lot of research. I've never explained pain out of a person. I've never sat with the patient, told them about pain. They stood up and said, I'm pain free. If I could do that,
you wouldn't be doing a podcast with Phil Plisky at that point.
We would probably just be doing it on a yacht somewhere. But
right.
No, but that's the point. What P&E does, it calms you down to do what? All the cool movement stuff we do. What makes people better? Movement, exercise, stretches, manual therapy, all the cool stuff we do. They're just afraid to do it. What P&E does, it just calms your system down, non-pharmacologically, by the way, that you can now do your straight leg raises like you mentioned. And I hope they don't do that anymore. But
right.
By the way,
we're working every day on that, Adriaan. We're working every day on that.
Is that one of your pet peeves? I have to ask you. I never remember.
Well, like there is one. My pet peeve is not the straight leg raise. My pet peeve is absolutely that I have a diagnosis and I can give exercises based on a diagnosis. That's my pet peeve, because that doesn't take any skill at all. I might as well. I can do that without even thinking.
All right. I just wanted to check and make sure you're okay as we do.
Yeah, exactly. Yeah, exactly. So okay. So we've talked about what the criteria are for what would be leaning to show that someone would be more successful. And I also think, I kind of hear we can kind of grade our amount of education and our timing education based on all these factors that we're seeing. I think I hear that. But what are the things, could you just, we mentioned them throughout, but could you just list a few things that are like, what are the things that are signs that we probably need to go a lot lighter, stay away, that this is not going to be successful, that a sit down with the person and have a 5-minute conversation about pain is just not going to go well. What are those things?
Yeah, I mean, a big part of it is that pre-contemplators, right? The patient just walks in, he doesn't want to be there, he has no intention to be in therapy or whatever, not even interested in this. Patients that walk in and say, I've heard about this pain stuff, whatever, I don't want that. We have patients Google us all the time ahead of time in our clinic, and they're like, I've heard that pain stuff, whatever, I don't believe any of that. The worst thing I can do is to go do it, right? It's just like somebody walking in and say, I don't want dry needling. Right. Well, let's stick a needle in you, right? It's no different. It's just we listen very carefully. On the flip side, though, Phil, the one I always talk about weekend classes is this. Imagine this afternoon my clinic walks in a high school volleyball player. She's a high school kid. She just sprained her ankle yesterday. She's not fear avoidant. She's not catastrophizing. She's just excited to get on the field. If I spend 45 minutes telling her how pain works and don't do any range of motion, balance, proprioception, strengthening, straight leg raise, do all those things, and she walks out, I have done this little girl and her mom and dad a disservice. She needs therapy without P&E. So that comes with the question, does everybody need P&E? The answer is no. Now, people that follow what we do will say, well, that's blasphemy. Everybody needs a little bit of kindness. No, I think a patient that is not fear avoidant, not catastrophizing, an acute injury, very clear goals, want to get back to, they need therapy. I'm not going to waste my time. Let's get you back on the court. Let's work on range of motion, strength, balance, proprioception, boom, boom, boom. And I think that's where the essence is where we need to be. Now, on the flip side, if she walked in fear avoidant, I may spend a little bit of time and calm her down and then do my range of motion.
Right.
So it's that beautiful dance between those. Yeah.
That's fantastic. If there were words that you could remove out of rehabilitation professionals' vocabulary when they're talking to a patient, you have now the master delete button in rehab education, rehab patient interaction. Could you give me a few of those words that you would just be like, man, use this so sparingly? Like this is a last resort. Yeah.
Torn, ripped, rupture, bulge, herniate. Those are just horrible. They've been studied extensively. I mean, there was an amazing, and people can look it up. There was an amazing viewpoint paper in JOSPT a while back in 2018 called Sticks and Stones that showed all the bad words we use and beautiful alternatives. The 2 authors that did it, just total shout out. It was amazing. And if therapists can just take some of those words, when I speak at medical conferences and physician conferences, I always show those and say, stop using these, please start using these. And, Phil, you and I are very technically based. We are evidence-based, whatever, but the research shows us the word sprain and strain, as benign as it is, you and I will kind of like say that doesn't say is actually very comfortable for patients. As an example, A sprain and a strain is, if we look at the brain scan research, whatever, doesn't light them up. But tear, rip, rupture, bulge, hernia does. And so, can we just soften that language where they go, yeah, I did hurt my muscle, but I'm going to get better. The guy at the funny accent said so. And
that's so, that I did not know that. And that's so interesting. And it brings me to my kids. I got 4 boys and they've got two physical therapists, athletic trainers as parents, right? I mean, they just don't have a chance in the world. Right. But they'll come to me with some injury, and sometimes it's major, sometimes it's minor. And they'll be just like, oh, it's just strained, right? That's not a problem. That's that I know that's going to get better. But if they were said, no, it's torn, we've got a major problem now, right? Because torn can't get back together, can it? Yeah. That's so crazy. So sometimes medical words are okay. Now let's take us through how you would, let's go into, we gave a great example of this volleyball player with an ankle sprain. Let's go through what you would do with that person who you're trying to get out of the pre-contemplative phase, right? So what would that look like? Because I mean, we don't want to just let them sit in their pool there, but we also recognize, I like it. It's a journey, but our goal is to bring them along on the journey, not just go, yeah, I see you're on the journey there. And it's going to be a rough one for you.
No, that's a brilliant question. So Phil, I'll give you an example, right? Again, I want people to understand, people that are pre-contemplative are not bad people. We're just catching them in a different part of the journey. And so I'll tell you an example. I had a truck driver walk in one day. He's a truck driver. His work comp is hurting. They're treating him very poorly. So he walks, he's already upset. And I ask him, what brings you here? I get back pain, whatever. And he's just angry. I don't want to be here. My job sent me here or whatever. Everything said, no. And he had that, Phil Arns full kind of a thing. Right. What we do with a patient like that is, first of all, we show them compassion, empathy, and respect. They're a good person. And I would just ask them, tell me about your back, same as you guys. What makes it better? What makes it worse? The standard questions we'd ask them. And then what we typically want to do is build a relationship. Now, he's a truck driver. Now, the lingo for truck drivers would be things like, are you local or long haul? Now I'm using his language. Or maybe a patient walks in, and I'm going to pick on the Packers again. He has a Packers jersey and, you're a Packers fan. You just, there's that human part. And this truck driver is just like, yeah, I'm local now because, I got little kids at home. Oh, that's cool. So what days do you drive? But now we're having a human interaction. Right. And then what I would encourage therapists to do is do very benign therapy. And I mean, no disrespect, but I would just say, okay, who did you see last time? Well, I saw Phil, and he showed me a bunch of stretches. Would you mind just showing me those real quick? And he shows me some of the stretches or whatever. So we do some nice, gentle stuff. And heaven forbid the podcast will have this, but I would slap a nice little modality, a hot pack or a cold pack on him, and just sit. And this is the mistake they make, Phil. I always tell the residents, I don't leave the room. I don't just walk out to my next patient. I just park myself down and just ask him more about truck driving or the Packers this season or whatever. In 9 out of 10 cases, a patient would turn to me and say, I'm sorry. And I said, what are you sorry about? I've been a jerk to you. I said, no big deal. I can only imagine how you must feel right now. And then he turns to me and says, well, what do you guys do here for back pain? Well, now we move to contemplate it. I said, well, in our clinic, we strongly believe in movement, getting your back better, blood flow, oxygen, all the cool stuff. But we also believe that people know more about their pain, they're better for it. So, for example, you told me when it's cold, you feel your back. If you want to, I can explain that to you, but that's completely up to you. So now we're just planting again little seeds, and he can choose to go, yeah, tell me more, or no, I'm good. Right. We just build this, and it's an amazing process as you work with these patients. And sometimes you walk 10 of these visits and they're not any better. And you say, but it's very nice to meet you. And, good luck with the next phase.
Someone can help you, but right now it's not me. Absolutely. And wow, I think that's, gosh, if we could just somehow, put that in an education pill for our rehabilitation providers, that would go a long way. That's a hard skill to teach because, one of the things, again, in the leadership realm, that what you just described is actually the science of negotiation. So negotiation is not about winning. Negotiation is about seeing the other person's perspective and understanding where they're coming out. And that they feel heard and they feel understood, and that you then get to how can we get to common ground. And I think we miss those steps of understanding trying to understand the person's perspective, having them feel heard, having them feel understood before we get to the common ground. I think we go right to the goal. Oh, you're a truck driver, so you have a goal of getting back on the road. It's like, that's not my goal at all. Or what's your goal? My goal is to not have back pain. Okay, well, we've got a common goal. Yeah, but we don't have a common ground, right?
Beautiful. Absolutely.
So with that, can you if we were to talk like maximum impact here, how can we, implement this well? What would be the top three actionable takeaways that our clinicians can put into practice right away?
Well, the first thing is you have to learn about it. I mean, it's as simple as that. The cool thing is, Phil, pain neuroscience education is now part of many schools are incorporated in graduate school. It is at CSM front and center, NATA, these colleges. So first thing is get yourself really well versed in it. We talk about the iceberg effect. That 10, 15 minutes I sit with the patient, underneath it is this huge knowledge base, right? So first of all, there's a saying out there that is, you have to be smarter than your patient. And I mean, no disrespect, but you must know your stuff. So don't try and teach somebody about pain if you don't know it, because they will derail you in a second. They live with it every day. So you must know it. Number two is, I want to go back to, Theodore Roosevelt's quote again. People don't care how much you know until they know how much you care. So really get to know the person. What brings you here? How can I make your life better today? And then really just planting seeds. In the old days, we gave you a fire hydrant, and that was the way it worked. And it didn't work right away. It never does. Education should be paced just like exercise. So what do we do day one post-knee replacement? We do nice little knee slides, simple range of motion. Straight leg raise, don't forget that one. And then we plant little seeds, and we just plant little seeds, water with compassion, empathy. And then we just blend it beautifully with all this movement stuff we've been doing so well. And then just watch what happens in front of us. And in most cases, they do great. That's
fantastic. And I think that's the take home message, for me is, I think what I've seen is people, will get educated. Therapists will get educated. And then maybe this is not the right analogy, but I see them like beating people over the head with neuroscience pain neuroscience education. And it seems that maybe 1 or 2 out of 10 it works. Probably 5 don't have any effect, and 2 people flip them the bird on the way out, right? And so that's not what we're talking about here. We're really talking more about developing a high quality relationship with your patient, using the right words, refraining from certain words, doing education that is very targeted and appropriate for the right person at the right time. No different than anything else we do as rehabilitation providers. Is that a fair summary?
Absolutely, 100%.
That's fantastic. Well, I've really enjoyed this time here. I do want to hear, what are you currently working on?
Oof, how much time you got? We do a lot of research. We do a lot of cool stuff. I mean, the coolest thing we're working on, Phil, is we built a pain program for middle school kids in America, and 9 states are using it. We work in pain literacy. Can we teach tomorrow's adults, today's kids, more about pain? So when they do hurt themselves, they go, yeah, I got it. So that's a big part of it. We're expanding it in different languages all over the world. So we're trying to just get work on pain literacy, I think, is a big part of what we're working on right now.
That's fantastic. That's incredible. As we wrap up here, there's so much to this. I've learned so much from your MedBridge courses. I've taken other courses from you. How can people connect with you more? Is it through courses? How can people, contact you, that type of thing?
Yeah, unfortunately, I'm the old guy here, so I don't do a lot of social media stuff. I've just made a willful decision. Obviously, MedBridge is a great platform. That's where a lot of people get exposed to it, etc. I work at Evidence in Motion. We do courses there. People can probably just Google me, find me pretty easily. And by the way, I do love emails. I'm the old guy, but send me emails. I answer them. I promise I do. Always happy to help clinicians, because I was on the other side where I emailed very important people, and they were very kind to me, and that's why I'm here today. So people can just Google, find me at EAM, and just email me, and I'd love to chat with people.
Oh, that's fantastic. Well, we sure appreciate your time. If you want to connect with me, I do have that same philosophy. You can find what I'm up to do or what I'm doing at philplisky.com, what I'm learning, because I think we're all on this journey together. So be sure to check out Adriaan's courses on MedBridge. They're pretty amazing if you haven't already. But that has been so awesome. So great to talk to you. Looking forward to maybe our next conversation.
Thanks, Phil.
Fantastic. Well, until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcasts@medbridge.com. See you next time.